This is an MS News Now program. It's the updates in Medicare costs, authorizations, the insurance process, and future MS generic medications, as well as biosimilars. And for those that don't know me, well, that's me, younger version, but that is me. And tonight's program, we have quite a few sponsors. We have Sandoz, Sanofi, Genentech, Bristol-Myers, Squibb, and Biogen. We want to thank them all. I thank them all. I hope you all do too. Tonight's program, again, you heard about it just a moment ago, and it's with Dr. Gary Owens. For those that were online last week and a few weeks ago, you got a taste of Dr. Owens, his intelligence, all that he's about to bring to you. All right, great. Dr. Owens, take it away.
As always, Stuart, thank you for the kind invitation, and thank you for having me back to chat with our audience tonight about Medicare. We'll talk a bit about some updates in Medicare, maybe give you a little lesson in Medicare, including even a little bit of a history lesson in Medicare for those of you who may not be totally familiar. I will talk a little bit about the appeals process in Medicare, which is, what happens if Medicare doesn't or says no to something that I need. And if you were at my previous presentation, that section, just a handful of slides, may be a repeat lesson. And then we're going to talk about where we are in the MS drug landscape for generics and biosimilars. So I'll just give you a little bit of background on me for those who haven't attended one of my sessions before. I started my career as a primary care physician and spent almost a decade and a half as a practitioner in northern Delaware, which is still where I reside in the state of Delaware. I then worked in the Blue Cross system for about 22 years, and for the last decade or so, I've been a consultant in market access, medical education, and a number of other things to healthcare companies. I do have a personal as well as a professional interest in MS. I've lectured not only at MS Views and News, but also at major national payer meetings, as well as published on the subject, and actually serve as a consultant to developers of technology and drugs in the MS space. And then have two family members with MS, one son and one niece, who are at very different points in their disease journey. My niece having had the disease now for more than 25 years, and my son just going into his 7th year with the disease. So there are many reasons why I like to join Stuart and this audience to chat. So what we're going to be really talking about is an overview of Medicare, what Medicare costs, to refresh you about that. And yes, if you are a Medicare enrollee, Medicare sends out lots of information, and including an annual Medicare update, which the good news is it has everything in it. The bad news is it runs on to close to 100 pages, so it's not the easiest reading in the world. Talk a little bit about Medicare drug coverage, and how that is evolving. As I said before, talking about the appeals, which may be repetitive, and then talking about generics and biosimilars. So I just want to give you some things about Medicare. We're actually going to start with the next slide, which is the ABCs of Medicare. And in Medicare, of course, as you may know, there are 4 different Medicare parts, and how they're alphabetized may seem a little bit irrational, but I'll explain that. Part A was part of the original Medicare Coverage Act back in the 1960s, and that was intended to cover hospital stays, skilled nursing care, some home health care visits, and later hospice care was added to Part A. And then Part B covers the physician visits, outpatient services, drugs that are administered in a physician or outpatient office, typically by supervised injection or infusion, and home health. And actually Part C is managed Medicare or Medicare Advantage, where health plans contract with Medicare. And actually Part C is a combination of parts A, B, and D. And that may be the thing that seems a little irrational because, well, how does part A, part B plus part D equal part C? And the simple answer is Medicare Part C came along before Medicare Part D was launched in 2006. And so when Medicare D was launched, it was folded into Part C. As you know, basically Medicare is federally funded. It's funded by a trust fund as well as taxpayer dollars. You pay Medicare tax. It was created in 1965 by legislation during the Johnson administration and launched in 1966 and was initially only for people over the age of 65. But things change. The program was expanded in 1972 to cover people under the age of 65 with long-term disability, and then later certain chronic diseases like end-stage renal disease were added. And, really Medicare does play a key role in providing coverage and financial assistance to over 60 million now people as we're becoming a much older population in the United States. And so what does the program pay for? And it doesn't pay for everything and every bit of everything, and we're going to go into some detail, but for the most part, it has basic benefits that cover hospitalizations, your doctor visits, whether they're primary care or specialty visits. It covers rehabilitative and preventive services. Prescription drugs are covered under Part D, which is purchased separately unless you're in Medicare Advantage. You also have hospice and skilled nursing facility coverage and home health care coverage. One of the things it does not do, though, is cover long-term care that is not skilled. So let me give you just a little history lesson in some of the major points in Medicare. I already told you legislation was passed in 1965 to launch Medicare on July 1st, 1966. And in 1972, the first expansion of the program was for disabilities and ESRD. And then they realized in the early 1980s, in 1980, to be exact, that even though Medicare had substantial coverage, there were some gaps in coverage, as you know, and I'll explain more. And that's when they allowed private insurers to sell what's called Medigap or supplemental coverage. And all these programs are rigidly controlled by federal oversight, even though they are not federal but privatized programs. Then in 1982, hospice benefits became available. And as I put in the arrows there's some of the big changes, some of the big milestones, the Medigap and the expansion to disability. So let's move on to the next slide. In 1988, Congress recognized that there needed to be an infusion of money in Medicare as medical costs continued to rise. That was about the time that we had the first $1 trillion healthcare budget in the United States. And so they created a sliding scale, both up and down for people with more or less income. So the premiums you pay for Medicare became means tested. And then in 1990, remember those Medigap plans that were started in the 80s became even more regulated and more standardized. So that you were buying essentially the same thing from whomever. And then in 1997, Medicare Part C, remember I said it came before drug coverage, which as you can see there is Part D that came in 2003 to 2006. In 1968, Congress recognizing that there was a financial need on both the part of some patients, Medicare enrollees, as well as infusing extra money into Medicare, that they created a sliding scale, which was means tested. So the amount you pay for Medicare Part B premium could be adjusted upward or downward. Of course, then those with more ability to pay were actually helping fund a bit more of Medicare. And then in 1990, Congress passed a law standardizing Medigap coverage. So the Medigap coverage plans that you buy are pretty much equivalent, except in things like price. Medicare Part C came along in 1997. That's why it's named C, because it was the next logical sequel to Medicare Parts A and B, even though now it's Parts A, B, and D rolled together because, as you can see in this slide, the bottom red arrow, Medicare Part D, came along and was launched in 2006. And then finally, just after the implementation of the Affordable Care Act, affectionately known as Obamacare, which brought with it free preventive services in the commercial space, Medicare also adopted first dollar coverage for preventive services that are approved and recommended by the U.S. Preventive Health Service Task Force. So there are other preventive services out there that aren't recommended by the task force. They're covered under standard coverage terms, but those that have the blessing of the task force, you get first dollar coverage. So as we move on, so let's talk about Medicare Part A. I'm not going to get into great details, but some of the things you want to know is what happens. Well, as you turn Medicare age, you're automatically enrolled in Part A when you reach eligibility, which means typically age 65 or disability or ESRD. For instance, as I pointed out, it covers hospital stays, hospice care, skilled nursing, and a few other minor services. There's no premium in this. You're not paying for your Medicare Part A, but you do help supplement Medicare Part A because you have a deductible, which means you have to pay this before your Part A coverage kicks in, unless you have supplemental coverage, which may help offset all or part of your deductible, or you're in a Medicare Advantage plan, which may also do that. And what is your deductible? It's not insignificant. It's $1,556 in 2022. There are some other limits you do need to know, because there are ways that you can run out of coverage in Medicare Part A. Basically, over in the upper left-hand corner of that diamond-shaped area, notice that Medicare pays for all or virtually all for your first 60 days of hospitalization. But then you start to have to pay a co-insurance, and a co-insurance is you pay part and Medicare pays part. And so days 61 through 90, you're paying $389 per day. So that can be pretty substantial. And then days 91 and beyond, you're actually paying $778 co-insurance for each lifetime day. And Medicare covers 90 days per benefit period, which means, Medicare covers the first 90 days, and then you have to have a 60-day gap in hospital care to start that over again. But you do have a bank of lifetime days that you can start using at day 91. Now, the good news is you have that bank of lifetime days. The bad news is the bank of lifetime days, and once you use them up, you've used them up. So long hospitalizations can begin to become quite expensive. And as you might guess, the number one cause of bankruptcy for senior citizens is medically related, because even Medicare doesn't cover everything. But again, your supplemental coverage can offset much of this cost. And also, I just wanted to point out that drugs given in an inpatient stay or a skilled nursing facility, you don't pay for those. Medicare pays for those as part of what they call their prospective payment system, which means they pay on a fixed cost system for your hospital stays, and you pay nothing extra for those drugs. So if you get started on a new drug in a skilled facility or hospital, you're not paying anything out of pocket for that beyond any co-insurances or deductibles. What about Medicare Part B? Well, first of all, you don't have to have Part B, but the vast majority of Medicare beneficiaries do, because it is that part of Medicare that covers physician and outpatient services. It does have a premium that's means tested, as I alluded to in the beginning. In 2022, that range goes all the way from $170.10 per month, all the way up. If you're fortunate enough to earn enough money to pay this, it's probably not as big an issue, but it's $578.30 per month, which is well over $7,000 per year. The deductible in Medicare Part B also exists, not as steep as A, which is over $1,500. It's $233. But here's the big issue, and why you need, if at all possible, to have supplemental coverage. Medicare Part B is an 80-20 plan, which means you, the beneficiary, have to pay 20% on all services that aren't considered preventive and 100% coverage. So that's why you can buy supplemental coverage or take Medicare Part C. And for those who are on drugs, and many, if not most MS patients are on certain drugs, drugs covered under Part B are generally those administered in a clinic, physician's office, require professional supervision. Could be by home health too. If your home health nurse gives them at home, they're usually IV. And those are covered under Part B and subject to that 80-20 plan benefit unless you have supplemental or Part C coverage. So what's in Part B more specifically? This is where your doctor visits, your specialist visits, your primary care visits, your visits with other service providers like podiatry. Also covers outpatient surgery, lab, radiology, including your MRIs, CAT scans. It covers ambulance. Part B covers preventive services, and again, first dollar coverage for those endorsed by the U.S. Preventive Health Services Task Force. It also covers things that you might need in MS, medical equipment, prosthetics, braces, wheelchairs, walking assistants, hospital beds, as long as they're prescribed by your physician, that's in Part B coverage. And so what is Medicare Advantage? Well, Medicare Advantage, or what are called Part C plans, are really all-in-one alternatives to having Parts A, B, and D. They're all offered by private companies. Some of the big names in that are some of the big insurers, the Blues, Aetna, Humana, United Healthcare, Cigna, just to name a few. And these really actually, as I've already told you, roll Parts A, B, and D into one coverage. In this case, Medicare is actually paying a fixed amount for every enrollee. So when you sign up with, say, a Blue Cross plan or a Humana plan or a Cigna plan or an Aetna plan, Medicare then pays that plan a fixed amount per month to provide all of your care. So in that case, the insurer is bearing the risk for your care. And in these plans, you have both the medical and pharmacy benefit integrated into the same plan. So whoever is your Medicare Part C carrier who's providing hospital and outpatient coverage is also providing your drug coverage. You don't get separate drug coverage in those plans. And here are the big players in Medicare Advantage, and I already told you about them. United, Humana, Blue Cross and Blue Shield, and CVS Aetna. Probably 2/3 of the people are enrolled in one of them. And back in 1919, that was about 22 million people. And now that number has actually increased in 2022 to almost 32 million people. And if you were paying attention and remember that I said Medicare covers about 60 million people, now more than half of us who are Medicare beneficiaries, yes, I'm one of those too, are covered under a Medicare Part C plan. So it has grown in importance and patients signing up for Medicare Part C. And here's an example of the components. And what this really shows on the left-hand side is you get Medicare Parts A and B, and you have to buy Part D and supplemental coverage separately. Over on the right-hand side, the Part C side, you have all together. And so if you look at it, and this is just averages, and I'm not saying this would always apply to you because it's going to depend on what plans you have in your area, and you have to do your homework. And if you do hear noise in the background, that's some proximal thunder. And I'm just going to keep my fingers crossed that we don't have any more glitches. But Part A, no premium. Let's say you're in the lowest tier, your Part B premium is 170. And on average, your supplemental coverage about $43 a month, although depending on the intensity and type of supplemental coverage you buy, that can range as high as $270 a month. So basically, if you buy the components individually, on average, again, and averages mean just that. It's kind of putting all the data together. You're paying somewhere in the neighborhood of close to $300 all the way up to close to $500 a month. On the other end, Medicare Advantage because Medicare is paying that fixed amount to the health plans. The average premium in Medicare Advantage is usually well under $50 and often in that 19 to 22 or 25. And they're even in some regions what are still called zero premium plans, which you're not paying any additional premium. And you may have heard those advertised heavily on TV, that you may have no out-of-pocket cost. And then Medicare Part D, prescription drug coverage. That's the baby of the Medicare 40-year gap between 1966 when it launched in 2006. The designers of Medicare in Congress back in 2006 did not envision the cost of prescription drugs in the new millennium, and basically that's why drug coverage didn't launch until 2006. Part D is not free. It's a little bit complex, but because it still does leave you with some drug cost, which I'll do my best to explain the complexity on the next slide. And it's a little graphic heavy, and it came to me thanks to the Kaiser Family Foundation, which I think did the best job of this. But in 2022, and I'll get you to focus over on the right-hand side of the slide, if you take a standard Medicare Part D coverage, and why I say standard is because Medicare Part D plans are allowed to provide actuarial equivalents, which may and do look different from this. So only if you have a standard Part D coverage, you have a deductible again. You're going to pay the first $480 of your drugs. And then for those drugs that you get between $480 and $4,430, you have a 25% coinsurance. And then once you get above $4,430, you're in the coverage gap. But most of that coverage gap is covered by manufacturers. So drug manufacturers subsidize your coverage gap coverage. In the original law, as it was designed in that coverage gap, you paid it all. But now that's down to 25%. The other 5%, that difference between 95 covered by you and the manufacturer, is covered by the Medicare Part D plans. And then once you get above $10,690 in spending, or you reach what's called your maximum out-of-pocket cost of just a little bit north of $7,000, basically you then only pay 5%. But if you're on very, very expensive drugs, let's say you're on a $100,000 a year drug, 5% of that, as you know, is still a big number, $5,000. So there are still the potential to be substantial out-of-pocket costs for your drug coverage under Medicare Part D. Also remember, again, those actuarial equivalents that can modify or eliminate much of, but not all of, your out-of-pocket cost. Who are the largest Medicare Part D carriers? There are going to be some familiar names here: United, Humana. The PBMs get in the business here with CVS, and then there's WellCare and Cigna and the Blue Cross plans, and that makes up 3/4. Total Part D enrollment is almost 45 million people in 2019 and has surpassed 50 million people in 2020 out of the 60 million. So most of us under Medicare have some form of Part D plan, whether it's through your Medicare Advantage program or separately purchased Part D. And here's what I was talking about. You're seeing far more drug coverage now being under, not far more, but 21 versus roughly 19 million. But as you can see, the number of people getting their drug coverage in those integrated Part C plans has grown and will continue to grow. There's still some employer group coverage under Medicare. Some of those are for retirees and others for active Medicare eligible employees. And what are some of your Part D premiums, or actually Part D costs here? And this is something I think you need to be very familiar with, because Medicare allows your drug plans to have multiple tiers of their formulary. If you were at my first lecture back in June, we talked about formularies and formulary tiers. But the generics that are preferred on your plans typically have anywhere from $0 to $5 out-of-pocket costs. So, that's generally what you're going to pay for preferred generic. So in any place where you can use a generic, it makes sense financially to use a generic. There's then a second tier of generics, typically which are called non-preferred generics. There, your cost can be anywhere from $1 to $19 and typically around $5. If you have to be on a branded drug, and that's a branded drug that's not a specialty drug, and for Medicare, specialty is typically defined as a drug costing more than $830 a month, you're going to pay anywhere from $30 to $47. That averages about $42. And here's where your cost really jumps up. If you're on a branded drug, which is non-preferred, you're going to pay anywhere from 30 to 50%. Remember that name, co-insurance, where you pay part and insurance pays part. And on average, you're going to pay 40% of those non-preferred branded drugs. So again, 40% of a $200 drug is $80, for instance, just to give you a for example. And on average, you pay 25% for specialty drugs, but remember, they cost over $830 to thousands and sometimes even $10,000 or more a month. And that could go up to 33%, but on average, you pay 25%. So it always behooves you, if you're on one of those drugs with a co-insurance, talk to your physicians about what your options are, because you're better off with another option than you are not being able to afford a medically necessary drug and perhaps not taking it and suffering the consequences. And there's been some good news. This is all news this week, right? The first good news is Medicare noted that the basic monthly premium for standard Medicare Part D coverage actually going to go down in 2023. And you think, gee, we're in an era of very high inflation. How could that be? And it's actually because Medicare beneficiaries are spending less money on drug coverage. Now, before you get all excited, it's a 1.8% decrease, down on average from $32 and some change to $31.50. So you're not going to be able to get a Starbucks every month on the difference in your average Medicare Part D premium. But I think there's a bit of good news on the horizon if you're a patient, maybe not such good news if you're a pharma manufacturer or a study or one of our sponsors, and that's Congress just released a plan for Medicare to negotiate drug prices, starting on 10 drugs in a couple of years, but moving outward over time to up to 100 drugs. So much like our colleagues in Europe, in the European Union, the governmental programs will have some price leverage negotiation in the future. And Medicare wants to listen to you on their enrollee. This was just last Thursday, a week ago today. They want to get feedback on the agency's vision to ensure that it's meeting your needs. And they're going to launch a bunch of initiatives to probably contact enrollees or create town hall meetings. It's not clear what they're going to do to get feedback on how Medicare can be made better. And again, remember, it was conceived in 1965, launched in 1966, and it has evolved. But now we're in 2022, and we're in a whole new era. And I think Medicare wants to, or CMS wants to hear from you, the enrollee. So let me talk just briefly about exceptions and appeals, because as you know, sometimes Medicare doesn't cover something because of a regulation in Medicare, things called local or national coverage decisions, and sometimes your Part C plans deny coverage for something. So we'll work our way through what you can do, for that. Well, first of all, you need to know that challenging a coverage denial is a legal right guaranteed to all insured people, whether you be covered under public programs like Medicare or Medicaid or dually eligible, or whether you have VA, DOD, TRICARE, or those types of insurance. And all plans, including Medicare and Medicare Advantage plans, have to have an appeals process and have to set up timelines and deadlines that have to be met. Who can do exceptions, and what I'm meaning here, this is actually a preemptive strike. Let's say the drug that you're on is one that's not on formulary, meaning it's not a preferred drug. Remember, I told you that's going to cost you a lot more percentage coinsurance. And let's say you've tried and failed the drug or a couple of drugs that are on formulary. So your physician knows that the non-formulary drug is now the only drug in that category that's right for you. Well, one way is for him to prescribe it, and it's going to get denied, which means you have to go through all of the appeals process. But the other way is you can ask for an exception request, and the physician actually initiates that. Commercial and Medicare plans have these policies for exception requests, and basically they ask the Medicare plan, in this case, hey, here is my patient, Mr. Smith. My patient, Mr. Smith, has tried your formulary or non-formulary or your formulary products, and none of them are acceptable. I don't see any reasonable alternatives. Here are the reasons why there aren't any reasonable alternatives, and I would like to make an exception. And if you're granted that exception, you really don't have to go through the authorization and appeals process. But there's one caveat. As you know, Medicare excludes certain lifestyle drugs from coverage. And if that's one of those excluded drug, which means it's excluded by statute, the exception request can't be used for that. Another way, if you get a denial before you go through the formal appeals process, is what's called a peer-to-peer process. And that's the case where your doctor says, you know, I want to talk to somebody at the health plan. I want to try to plead my case. They usually get assigned a medical professional, a medical director to speak with who wasn't involved in the initial decision. It's a bit of an informal conversation called a peer-to-peer. But again, if that results by your doctor explaining to the Medicare doctor or the Medicare health plans doctor the rationale, basically coverage is granted and nothing else needs to be done by you, the member. So there's ways to deal with this preemptively. There's ways to deal with it informally, but invariably some of you are going to get that Dear Mr. Smith message. Your request for fill in the blank service has not been approved because fill in the blank why, and then it'll go on and give you your right of appeals. And I apologize, the next slides after this one will get a little busy. But this one, there's some limitations in the appeals process and the peer-to-peer for that matter. You know, your doctor or your staff has to be involved, although you initiate the appeal yourself. They may be pressed for time. I've actually talked to doctors who say, I'd love to do appeals on behalf of my patients, but I just don't have the time and I have to be available for my patients that are sitting in front of me. And the peer-to-peer process in particular is not highly regulated where the appeals process is. And so, you know, ultimately, if you do have to appeal, remember, as you see in the purple at the bottom there, you benefit from regulations in every state and federal regulations that guarantee you multiple levels of appeal. And in fact, in Medicare, you have 5 levels of appeal. And so let's appeals in Part B. In Part B, under Medicare and also in Part C, Managed Medicare, if you have to appeal a determination, that is a prior authorization, which over on the left-hand side is called a pre-service determination. First of all, that health plan has to give you that determination in 14 days if it's non-drug and in 72 hours if it's drug. But even there's expedited, as you can see, where they have to give you their answer in 72 or 24 hours. And then you have 60 days if you're denied to file an appeal. And again, if it's the standard appeal, the health plan has to give you an answer in a month, or for a drug in 7 days. And again, if it's considered expedited, usually means if that's so urgent that it's life or health threatening, they have to do it in 72 hours. To sum it up, you know, health plans have to give you their determinations. And if we're going to focus on drugs, they have to decide whether to cover not in 72 hours or 24 if it's urgent. you have 60 days to file an appeal. And if it's a drug, they have 7 days or 72 hours to review your appeal. And the next slide is even another level, and this is for Medicare Part D, and it's exactly like drugs in Medicare Part B. Basically, they have to review your appeal in 70, or your request in 72 hours or 24 hours if it's expedited, and then if you appeal it, they have up to 7 days to respond to your appeal, or 72 hours. I'm not talking about the payment denials, because that occurs after you've received something and whoever the payment is owed to is responsible for doing that appeal. But again, these processes are regulated. And my point is not for you to remember the times here and the time frames, because they're all easily available on the cms.gov website, or if you have somebody helping you with appeal, that they'll walk you through all of that. And the last slide, I'm not going to spend a whole lot of time in, because I hope you never get here. But if you are in Medicare, whether it's a standard or an expedited appeal, you actually have 5 levels of appeal. So you know, the next level of appeal is yet another internal level of appeal. And then if you still disagree, there's an external, that's what's called the independent review organization, and that can create yet your 3rd level of appeal. Then if you basically still disagree, you're entitled to hearings before an administrative law judge, and actually you can take this to federal court, but you can only take cases to federal court that are worth more than $1,760. And if you look at all these and you start adding up those 60 days and 60 days and 60 days, you're really getting out to more than a year. And the honest answer for most individuals, it's not really practical to pursue it to that level. So I generally tell people to focus on the information on that first slide, which is the initial review timeframes in your first level appeal timeframes. But do know that you can have up to 5 levels of appeal. But I can tell you that the number of appeals that go out even to administrative law judges and district court become diminishingly small, as you might guess. So now I'm going to close out in the last few minutes on a totally different, but I think very cogent topic for MS patients, because as you know, your therapies, I mean, the good news is, you know, I practiced medicine before we had any drugs for MS other than corticosteroids and supportive care. I was very involved in reviewing and making coverage policies for the first MS biologics, the interferons, back in the early 1990s, and then been involved in that process. We now have 23, yes, count them, 23 drugs to treat MS. That's the good news. You have lots of therapeutic options. There's not a one-size-fits-all for most patients, and you and your doctor often have to make personalized, informed decisions about what you're going to take. But that being said, they're expensive. And we do know, as I've talked about previously in my talk, and this is where these two pieces dovetail, when you have generics, generics can be quite inexpensive. And I didn't talk a lot about biosimilars yet, because biosimilars are exactly that. They are a loose equivalent, actually a metaphor of a generic. So if we show the next slide, I can show you the biggest difference. You know, basically generics, typically the drugs that have generics are made from small molecules. Typically those small molecules are produced from chemicals and chemical processes, and they're actually fairly easy to reproduce if you have good medicinal and organic chemists, and once you have the recipe for making these drugs, they can be made in large quantities and large batches. On the other hand, biosimilars are large, complex molecules, sometimes hundreds or even thousands of times larger than the small molecules. They're usually made in some kind of biologic process, meaning they're made from some sort of living cells. And so they're much more complex to make. You know, the recipe, so to speak, for making them is highly dependent on a number of variables, including what cells are used and the temperature of the process and the size of the process and who's overseeing and developing the process. So that's why I say they're more of a metaphor for generics than they are an identical thing to generics. And so, I thought the best way to do this, and I know we like to have a Q&A session after this, and we will still have a Q&A session, but I thought, gee, maybe one of the ways to do this is for me to think of some questions I would have if I weren't knowledgeable in medicine, and ask about MS drugs. So, the first is, how are approved MS disease-modifying therapies classified? Typically the oral MS therapies are classified as chemical medications, meaning they could have generics, and there are things like dimethylfumarate, teriflunomide, siponimod, fingolimod, monomethylfumarate, ponesimod, and glatiramer, and all those have brand names. And the rest of the MS therapies are classified as biologics. So as you can see, there's a group of these medications given orally that are classified as chemically produced structures, and they can have generics. The rest of the MS therapies are biologics and will need to have biosimilars. So the next question is, okay, so what's the big deal about biosimilars? Aren't they really identical? If we could go back for just a second to the reference products. And actually, I don't need to, because no, they're not exactly the same. Biosimilar means that, for instance, if I were asked to ask an artist to paint the same scene 5 days in a row, it would look the same, it would look similar, but there'd probably be little differences in brush strokes and technique, and maybe even a slight difference in perspective. But I think you'd all look at that picture and say, gee, you painted the Eiffel Tower 5 days in a row, and I recognize it's the Eiffel Tower and the Champs-Élysées and that sort of thing. And of course, they are highly regulated, and they can't have any significant differences between the original product or what's called the reference product. They have to be effective, safe. FDA guarantees manufacturing purity and potency. So now let's jump to the next slide. Okay, so the next question you might ask, will biosimilars offer as much savings as generics? And the good news is they will offer some savings in other areas where there are biosimilars out in those products, or rheumatoid arthritis, for instance. Some of the cancer treatments, we're seeing 10 to 35% discounts off list price, where generics typically reduce the price of many generic drugs by anywhere from 60 to 90%. So they will offer pricing relief, and when you multiply it by the thousands and millions of patients on a nationwide basis, it's a lot, and even significant dollars for you, because 35% of $1,000 is a lot more than 35% of $10. So the next question you might have, do I have to meet the criteria before my doctor can prescribe a biosimilar? And that's probably my biggest it depends answer. It depends on what your insurance company is going to do, or the biosimilar is going to be on formularies. Are they going to be approved by your insurance? Are they going to be covered by your insurance? And that sort of thing. And it's all going to vary by insurance companies. But yes, your doctor can prescribe a biosimilar. They're free to do that. And then the final question you might ask is, how can I find out if biosimilars are available? And really, I think the best way to go is to your healthcare team or your healthcare provider. They're going to be the best to help advise you. They often stay in touch with both the originator manufacturers and the biologic manufacturers. And really, if you're contemplating a biosimilar, again, it's another informed decision point with your doctor to talk about the pros and cons of going to a biosimilar, the switch versus saving money. I mean, saving money is a definite plus, but you want to make sure you and your doctor are both comfortable with that switch. So we still have a way to go in MS. Currently, there are generics available for glatiramer, which is Copaxone, which is an injectable, and dimethylfumarate, Tecfidera. What about biosimilars? The first application for natalizumab, also known as Tysabri, was submitted in July 2022. There are also applications out there for the older interferon beta 1A. There's still no approved US biosimilars for MS. And now, because of a number of issues, litigation issues, patent issues, there still may be some long delays before we see biosimilars in the United States. So the good news is they're in the works, they're in the process, applications are out there. The bad news is we don't have any just yet. So with that, I hope you've enjoyed tonight's talk. I hope maybe if you knew a lot about Medicare, it was a refresher. If you didn't, maybe you learned a few things and maybe learned some of your appeals rights, as well as kind of the state of where we are in developing generic and biosimilars for your medications.
Well, firstly, thank you very, very much for your talk. How close are we to a generic for Gilenya? And that's fingolimod.
Probably reasonably close. There's some litigation out there, but there are applications out there. I don't know the exact date, and I probably should have checked into that a little bit more, but it would certainly be probably the next generic we're going to see in MS, but I don't have a specific, and to be honest with you, it's hard to ever commit to a specific timeline because there's always last minute FDA inspections, maybe some last minute patent litigation that comes up, all those things that can sometimes delay these.
Okay, thank you. Elizabeth is asking, what is going on with the Congress Medicare bill that you mentioned? Will MS drugs be considered for that or not at first?
Not at first. They're going to be in areas like MS. I don't mean MS, rheumatoid arthritis. There are only 10 of them, a couple of cancer therapies. But remember, that's going to theoretically expand to 100 over time, which will give the government for its Medicare enrollees. But remember, that's only going to be Medicare. So, if you're insured by a commercial health plan, so far that may not have any impact.
Okay, thank you. All right, Michael's asking an interesting question. I don't know if you know the answer to this, but in your opinion, do most of the D plans, D as in dog plans, cover LDN, which is low dose naltrexone, since you cannot get it from a traditional pharmacy? That is a compound medication.
Well, the first thing I can say is all prescription drug plans under Medicare are required to cover compounded medications. That being said, virtually all Medicare Part D plans prior authorized, which means they have fairly strict authorization criteria for those compounded drugs. And if your doctor prescribes it, it would have to go through that prior authorization process and be approved based on whatever evidence-based or scientifically based criteria your health plan has. So the answer is compounded drugs are covered. This drug could be covered, but it will be subjected to prior authorization. And of course, that prior authorization process is going to vary dramatically from plan to plan.
Okay, thank you for that. All right, next, a person who's asking, is there anything new now covered with MS Care since COVID-19?
I guess the biggest coverage has been Medicare's expansion of telehealth and virtual services so that you can really have a visit with your provider by telehealth. And remember, Medicare opened that up wide during the initial phases of the pandemic and took away, before that, really telehealth was relatively significantly restricted by Medicare. You had to meet fairly rigid criteria of being homebound or not able to get to your physician's office. And telehealth services grew exponentially during COVID-19. But Medicare is re-looking at that, revising some of their reimbursement and maybe even some of their coverage rules. So we may see some rolling back. But that being said, I think telehealth is here to stay because let me give you a good example. You're a stable MS patient. You're doing well on your drug. You're not having a lot of problems. Maybe you only see your provider every 6 months. And maybe one of those visits every 6 months can now be a telehealth visit. and it makes it much more efficient sometimes for you and your provider. But it's still a work in progress. But I will say emphatically, telehealth is here to stay.
Yeah, thank you for that. Next person, Kristen writes, best way to get brand name Ampera. Can you discuss that at all? Do you know about this?
Yeah, well, certainly the best way to get brand name Ampera is, first of all, to have your doctor prescribe it, have them write it, dispense as written. Even then, it may have to go through a prior authorization process, and in some cases, brand name Ampera may not be on the formulary, which means it's a non-preferred drug, or in this case, a specialty drug, and you're going to have to pay, that percentage of 25, 30, 35, even 40%. I will say, talk to your doctor about the differences between brand name and generic Ampera in this case, because remember, Ampera is one of those drugs made of chemicals and therefore is virtually identical. Don't discount the value that a generic brings there. Now, you may have tried it and there's some reason why you can't take it, and I'm not privy to that, nor should I be. But if you do get brand name Ampera, you're probably going to have to go through a prior authorization process. Your doctor's going to probably have to justify it, and in all likelihood, you will pay more.
Great, thank you. And I want to add in a little bit something to that, and that is that Accorda Therapeutics does have a prescription assistance program that depending on your level of income or what you have or don't have, they may be able to give you the drug for free. Okay, so that is, you should contact Accorda Therapeutics directly. And if you don't know how, just send an email to me and I'll give you the information. Okay, all right, next. What's the process or what is necessary to get insurance help with either to get a power chair or a mobility scooter?
Well, first of all, your doctor has to evaluate you and prescribe it. Once it's prescribed, your doctor will need universally those, because of the cost of them, and because there's some, what should I say, less than scrupulous online vendors of those. Your doctor will have to contact the health plan. The health plan usually has a designated durable medical equipment provider, known as DME provider, who will provide this. Your doctor will have to provide the justification why you need it, and it will have to meet, again, their prior authorization criteria. If it does, yes, then your health plan will work with you, usually a case manager, to get that mobility device. If it's denied, remember, you always have those appeal rights, and you and your doctor can initiate that appeal. But it does require your doctor, whether it's a physiatrist, an MS specialist, your primary care doctor, typically those are the ones that would write for that, to really contact the health plan and go through the prior authorization process. And you basically are going to be required in most cases to use the health plan's designated durable medical equipment provider.
Great, thank you. So there is actually there's more than one person, but asking questions about you, and it seems like they might think that you're a neurologist. All right, forget that altogether though. Would you be, for you, for your son, for those that you know directly within your own family that have multiple sclerosis, would you be comfortable if they went onto a biosimilar and came off of a brand medication?
The answer is yes, I would be. In fact, one of my family members, without revealing confidential information, actually made the switch from a branded to a generic MS agent when it became available. He and his MS specialist discussed it carefully, and again, in that informed decision-making process, decided. He's been on it for quite a while now and has not seen any difference. Now, that's an N of one, an individual experience, but the question was, would me or one of my family? So I thought I'd use the anecdote of one of my family.
Sure, thank you for that. That's a great answer. All right, next, let's switch over to the Medicare stuff for a little bit, okay?
Sure.
Let's go back to that, I should say, right? So Medicare Advantage, for those that purchase a Medicare Advantage plan in certain states, we've heard that they are restricted to only then see medical practitioners within that state. How true is that?
Well, all Medicare Advantage plans are what are called network plans, which mean, yes, you are restricted to the doctors who are in the network. And for the most part, those networks tend to be in regional areas around where that health plan is located. So for the most part, yes, you're going to wind up seeing doctors in that state. But there's a couple of things that can happen there. One is if it's a large national plan, they generally have arrangements where you can see network doctors in other regions. Say if you're a snowbird and you have like one of the national plans like United and Aetna, and you have a United plan in the Northeast, very often during the 6 months or 5 months that you're in the South, you can get a temporary transfer to the plan where you're residing then, and back and forth. Blues plans do a similar thing through a cooperative network. And sometimes if there is a provider that's not in the network, but there's nobody in the network to meet your needs, then much like you ask for an exception for drug coverage, you can ask for an exception to see that provider. On the other hand, if you see one of those providers without getting the approval of the health plan, because these are network health plans, you could be responsible for all of the cost of that. So be very careful when you do that. And I hate to tell you, you have to go through the mother may I process, but do that to protect yourself.
What if it's an emergency? What if a person just happens to be out of town on vacation and they fall into a rat's nest, so to speak?
Exactly.
But yeah, you know,
it happens all the time. And again, under federal and state, well, federal regulation, mostly health plans, whether they're Medicare Advantage plans, commercial plans, and of course, standard Medicare is a nationwide plan. There's no network to that, are required to cover services that are emergent without subjecting you to network restrictions or prior authorizations. And if they don't, certainly you will win that appeal. Now, there is one caveat there, and sometimes what you perceive as an emergency may not be perceived as an emergency by your health plan, and they could say, let's say your tooth itched and you went to the emergency room. I'm making up an absurd example, and itchy teeth aren't truly an emergency. You could have waited. You may be subject to a denial there, but if it's a true emergency, you fall down and break your arm, it has to be covered.
That's right. That's right. Okay, thank you for that. Next, what are the pros and cons for Medicare Advantage Part C versus a supplement with the Parts A, B, and D?
Well, some of that was my talk, but I'll sum it up very quickly. The coverage is very similar in terms of they both cover inpatient, outpatient, physician-administered drugs, and prescription drugs. So the coverages are similar, although the limits of coverage and how much coverage you get can look very different. The main and larger difference is, as you heard in the previous couple of questions, is the Medicare Part C plans are network-based plans. So basically, you are going to have a more limited network, and that limited network may be hospitals, doctors, specialists, and even pharmacy networks. So you really need to do your homework a little bit, or have an insurance broker help you do your homework to understand what Medicare Part C covers, or what their networks look like, also what their formularies look like, and if your drug is going to get preferred coverage. So it does take a little investigative work. That's the limitation of the Part C plans. Now, as you saw, if you buy the components individually, that can be anywhere from $200 to $500 that you have to pay out a month for that coverage. And sometimes you get what you pay for, because the more you pay, probably the broader the coverage is. Where Medicare Part C plans range all the way from zero premium plans in very specific regions of the country to typically premiums that are $50 and no more than $100 a month in most places. So on one hand, you're trading off cost for convenience. On the other hand, you're spending less but getting the same coverage. And again, it has to be a decision you make personally. If everything you need is in a Medicare Part C plan, and it's going to cost you, $300, $400, $500 less, I'd say go for it. If it doesn't have everything you need, then you really have to weigh that decision very carefully.
Right. And going and staying with the same subject, but going with the out-of-pocket costs, the pros and the cons between the Medicare Advantage versus the Part B plans. The out-of-pocket costs, for the pros and cons of the Medicare Advantage versus the supplement policies, from what I gather, and I'm on an Advantage plan, but I know people that are using similar medications that are on the Medicare Part B plan, and the out-of-pocket is greatly less. Yet, though, I still see the advantage for myself with the Advantage plan.
Yeah, well, remember under Medicare Part B, if you're getting a physician supervised drug, it's Part B drug, it's an 80-20 coverage. But when you buy supplemental, a lot of times those supplemental plans will pretty much cover the rest of the 20%, if not all of it. So if you're on a physician administered drug, it may well be to your advantage to have an 80-20 plan as opposed to it being a specialty drug in your Medicare Advantage plan and costing you more. On the other hand, if it's a self-administered drug, probably your Medicare Advantage plan and the separate Part D plan are going to look a lot alike in the out-of-pocket cost, depending on, of course, formulary status, that big word.
Right. What about age limits between the two?
Between Medicare Part C and
so Medicare Part C Advantage, you primarily, except with a couple of the companies, you have to be at least 65 years old in order to be in the Advantage plan.
Right. Or, because remember, the only people under 65 who aren't who are covered by Medicare are either disabled or have ESRD, or I think ALS might be under that banner too nowadays. And so the way it was written was basically, or the way the law said, it allowed Medicare Advantage plans only to cover those who aged in to Medicare because of the, quote, actuarial risk of those under that age. I think there are a few that might take those, but they're going to charge you a premium that probably makes it either equal to Medicare Parts A, B, and D separately, or maybe even worse than. I don't know. I never compared the prices.
Okay, no problem. No problem at all. A lot of these questions I just came up with because I know that there are things that have been asked of MS Views and News by people, and I just wanted to make sure that I brought that up with you here because you're the expert and we're not. So, okay. Another thing though, with the MS Meds and the Part B or the Medicare Advantage plan is, well, actually it's the Medicare Advantage plan. You were saying about specific drugs that or treatments that are physician controlled, and I know that the infusions are one of them. Is there anything else that, a medication that might be better with an Advantage plan to be fully covered versus the other?
Well, again, in typical, the Part B drugs, because they go through the medical benefit side of the house instead of, quote, the pharmacy benefit side. And again, once you've met your deductibles, remember that Part B deductible is not terribly high, not nearly as much as the Part A deductible. Usually, once you've met that deductible on the Medicare Advantage medical drug side, so that's one that's infused or has some kind of complex administration routine that requires a physician, you probably are going to get more coverage and even up to 100% coverage once you've met that. On the other hand, you sacrifice a little convenience, don't you? You have to go to an infusion center or an outpatient clinic to get that, versus if you're on a self-administered or oral drug, you have the convenience of taking it in your home yourself. So again, you have to weigh the pros and cons. There's no one absolute best choice fits everyone.
Great, thank you. All right, we're getting totally away from that subject now. Going to get away from Medicare, get away from medical, anything to do with the Medicare process at all. And we're going to go back to the biosimilars and generics, okay? Actually, before that, I'm going to go to something that somebody wrote in when we were talking about Ampera. She wrote that there's a company called Cost Plus Drugs, well, a website, costplusdrugs.com. It's Mark Cuban's lowest drugs website. And with regard to Ampera, that they have a way for you to get it for about $28 for a 90-day supply. So don't waste time with the insurance company, she says, or patient assistance and whatnot, and just get over to this website and get signed up. All right, that's one thing. Another thing is, okay, I got to skip some of these questions, except one of them with regard to the biosimilars and people getting off of it and your advice and whatnot. Again, I think I definitely know that you mentioned it, that it's not just a matter of just switching, but if you're doing really well on a brand medication like a Tysabri, since you brought that up, is there still benefit to switching to the biosimilar? You did say that it's like basically the same thing, but price-wise, you said it's greatly different. So would a person be better off doing that?
Well, again, it has to be a decision between you and your doctor. And I can't quote any data for MS, but there are a number of studies now in rheumatoid arthritis where some of the biosimilars have been out for a long time, especially in Europe. There's a Danish study, or a Scandinavian study, I should say, where the vast majority of patients switched from Remicade, which is a branded drug for rheumatoid arthritis, to infliximab. And they literally saw in thousands of patients in this Scandinavian study that there was virtually no difference in the outcomes of treatment. And even a more recent study I saw published in the Journal of the American Medical Association within the last 2 weeks has shown that actually switching between different manufacturers of the biosimilar, because they're more, has also not resulted in any issues that they've been able to find yet. So while they are biosimilars and therefore not identical, as I said before, kind of like that painter painting the Eiffel Tower 5 times in a row, the data we have in other disease states, does support that they seem to do as well. But again, it has to be a decision you and your doctor make. I mean, there's some doctors, and I know them, take the if it ain't broke, don't fix it approach. And therefore, if you're doing well, I'm not going to do it. And there are other doctors who are very comfortable making the switch with the idea, it's a bridge that you don't burn when you cross it. Basically, if you go to the biosimilar and it doesn't agree with you, or you don't see the same results, you can cross back over the bridge the other way, because the originator's still going to be there. I know it's none of us want to experiment with their health, but I guess you have to look at it is, if I'm on a biologic that I barely can't afford or have to make serious lifestyle choices between my drug and other things, and if the biosimilar has the potential to save you money and perhaps eliminate some of those issues, it may be a risk or a choice worth taking. On the other hand, it may not be. Again, it's not right for everyone. But just think about the experience with generic drugs in the U.S. when I first started in this business. Fewer than 50% of small molecule prescriptions were generic drugs. Now that number approaches 90 to 95%. And, so we've seen that massive transition. Once patents are out, that most people on small molecules convert to the generic drugs. I personally take a few maintenance medications, 3 of them to be exact. They're all generic, and all of my parameters look Harvard pretty. So again, it's an N of 1, but don't be scared of those things, but also don't take those decisions lightly. They do need to be made between you and your caregiver.
Okay, great. Thank you. All right. I think I'm out of questions. I actually think I'm out of questions. So, but I do want to thank Dr. Owens greatly for being online with us. This is his 3rd time online with us in the last month and a half. And I know it takes a lot of his day and a lot of timing to put it all together. But we're just glad to be able to have him bring his wisdom to show to all of you all and to provide you with this information. So again, thank you for being here. And Dr. Owens, have a great night. Everybody online, have a great night. and I hope to see you at our next event.
Right. And thank you for inviting me once again, Stuart. And until next time.
Great. Thank you.
Thank
Bye-bye.
you.